Welcome everybody to our TIF Talk Tuesday. I'm very excited about our special guest today, Dr. Ajay Bajaj. Thank you so much for being here with us tonight, Dr. Bajaj.
Oh, my pleasure. Thank you for having me.
Fantastic. My name is Andrea Millers and I'm with Endogastric Solutions. And if you have been watching our TIF Talks every Tuesday, you know that we are live today. So at any time, if you have any questions, please feel free to type in the comment section your question, and we will do our best to answer your questions. Also, if you are tuning in live, please comment where you are tuning in from, and you could win a iHeart TIF tumbler tonight. So welcome everybody, and thank you for being here with us this evening. We are going to talk about GERD and the TIF procedure. But before that, let me give you a little background on Dr. Bajaj. After medical school in India, Dr. Bajaj completed his internal medicine residency, where he served as chief resident, and also his fellowship in gastroenterology at the Chicago Medical School at Rosalind Franklin University of Medicine and Science. He is board certified in both internal medicine and gastroenterology. He focuses in all aspects of gastroenterology, including diagnostic procedures like EGD, colonoscopy, and ERCP, as well as management of the gastrointestinal conditions, with a special interest in hepatobiliary disease. He is an assistant clinical professor at both the University of Illinois at Chicago College of Medicine and the Chicago Medical School at Rosalind Franklin University of Medicine and Science. Outside of medicine, Dr. Bajaj enjoys travel, core conditioning, and spending time with his wife and his two children, both of whom chose medical careers after being inspired by his example. He practices with Illinois Gastroenterology Group in Oak Brook Terrace, Illinois. Again, we can't thank you enough, Dr. Bajaj, for being here with us this evening.
Oh, it's my pleasure. Thank you for having me.
Fantastic. So we're going to go ahead and start. Why don't we go ahead and kind of talk about what is GERD, Dr. Bajaj, if you can explain what is the scientific explanation of it, and also what could patients potentially feel if they were suffering from this disease?
Thank you for that opportunity. GERD means gastroesophageal reflux disease. What that means in essence is that the lower esophageal valve, which serves as a one-way valve between the esophagus or the food pipe and the stomach, becomes incompetent. So rather than maintaining a one-way flow of food towards the stomach and onwards, it starts to reflux back upwards or regurgitate upwards, causing symptoms which can be as mild as some acid reflux after a beer and pizza night to really, really significant symptoms of vomiting, choking, and sometimes extraintestinal manifestations such as asthma, airways disease, chronic sinusitis. So the manifestations are substantial and can involve more than just the digestive tract.
Right. Yep. So what are types of things that you recommend, or is there food modifications or lifestyle modifications or activities that patients should initially do to help with those symptoms that you just described?
See, first and foremost, all you have to do is go shopping. And it is very obvious to everybody that America is getting rounder and rounder. People are putting on weight without realizing it. And I think obesity or being overweight with a BMI of more than 25, that is the first thing that causes significant worsening of reflux and regurgitation symptoms. So lifestyle changes are important, but more important is to keep your weight in check. That's number one. Number two, in terms of what we eat, we should limit the quantity and give the body a chance to assimilate what we eat before we scarf down more and more stuff because it is so tasty. Thirdly, I think good sleep hygiene, people who sleep well tend to have much less acid reflux because the lower esophageal valve responds to good sleep patterns.
Hmm, interesting.
So, keeping your weight down, eating in moderation, sleeping well. I think common principles, like mom used to tell us when we were kids, I think those should carry on into adult life no matter what we do.
Is great advice. I love that. And there's always complaints about some foods or types of foods that kind of exasperate, if you will, uh, uh, the symptoms. What are those things that maybe people should not maybe not 100% eliminate, but be cognizant of, when they're going about their day-to-day life with these
I
GERD,
think,
these
I
GERD.
think, I think other than portion control, citrus beverages, especially orange juices, mixed citrus beverages,
Mm,
they are a big component. And then tomato sauces. So pizza, the main ingredient, which is tomato based, which brings so much joy to everybody, it also brings tremendous reflux with it. So it's a catch 22 situation. The
right.
tastier your food, the more citrus or tomato there is, the more fat there is, um, the heavier it is in composition, the more problem you will have because it will sit in your stomach much longer and you will have more reflux and regurgitation symptoms.
Right. Right.
And then to say nothing about alcoholic beverages, alcohol of all types tends to slow down gastric emptying. Therefore, you will get more reflux, more regurgitation, more discomfort.
Right. Right. So, there's always the conversation of, oh, if I have GERD or, severe acid reflux, I'll just take a PPI, or I'll just go, get Tums or, a Meprazole or whatnot at the drugstore. Can you talk a little bit about medication therapy for GERD and acid reflux?
Absolutely. See, the whole thinking process about doing all of life's sins and then taking a tablet for atonement, it's a great concept, but doesn't work quite that well in life. People who tend, there's an old saying that there is no prescription medicine that you cannot out eat. So you can take an acid blocker and then you go eat a little bit more, and then it won't be able to stop your acid reflux anymore. Therefore, any therapy that you take for acid reflux cannot be just one and done. It should include lifestyle changes, choice of proper foods, weight management, and then, of course, acid suppressive medication to prevent the symptoms of reflux or regurgitation and to treat some of the complications of reflux. Absolutely, there is a role for it, but it is not a panacea. One pill will not fix all of life's or all of reflux's problems.
So can you talk a little bit? There's some articles that are out there, some fear now that potentially long-term use of PPIs could cause some side effects. Can you talk a little bit about the use of long-term PPI use?
I can, and I'm happy to. See, the problem is now that acid suppressive agents are available without a prescription. There is nobody to stop anybody from buying them in excess or taking them as they see fit.
Right.
The problem with unfettered use of all medication is that there is going to be a downside. And with acid blockers, we have come to realize that acid is needed to protect the intestines from bacteria from other parts of the body. And so, overgrowth of bacteria, and then B12 deficiencies in the long run, and then calcium malabsorption and osteoporosis. A lot of those problems have come to the forefront, as have cardiac issues and kidney issues. So, even though these medications are felt to be safe enough to be sold without a prescription, they are not candy. There is a downside of each and every medication, including proton pump inhibitors.
Okay.
And I think long-term use of these has to be balanced against the efficacy and the side effect profile, especially in the elderly, especially in people who have osteoporosis. This may be a significant issue. Similarly, people who have heart disease or kidney disease and have concomitant reflux, they may need to rethink the strategy of taking long-term acid suppressive medication.
Yeah, perfect. And I'm seeing some questions pop up in regards to what types of tests can you take to determine whether or not you have GERD. And actually, we have a question from Santos is saying, can you tell if you have GERD via colonoscopy? So maybe we can, maybe you can talk about the different diagnostic tests that you do to determine whether or not a patient has GERD or acid reflux.
Thank you. Thank you. Um, See, the main test that we do to identify acid reflux is the upper endoscopy, or what we call EGD. Um, that looks at the lower esophageal valve, estimates how loose it is, grades it from Hill 1 to Hill 4, sees the length of a hiatal hernia if there is one, and then checks the esophagus for damage such as esophagitis, or if there is any other issue with the esophagus such as a stricture. You cannot diagnose reflux with a colonoscopy, but one question that commonly patients ask is that can my ENT surgeon, when they do direct laryngoscopy, tell whether or not I have reflux? They can get an idea, but to get the best idea, you have to do the best test, which is the upper endoscopy. Now, sometimes we piggyback other tests on it. The most commonly one that is being done is called a Bravo or a pH probe, in which a small probe is left inside your esophagus after the endoscopy is concluded to check your pH for 48 hours to see how much acid reflux you got, whether you got it before or after meals, whether you got it when you were upright or supine, awake or asleep. So it can be used as a stepping stone towards more data gathering. But the upper pan endoscopy remains the workhorse of trying to identify who's got reflux and who doesn't.
Fantastic. Thank you for that. Now, can you talk a little bit about all of the different treatment options right now that are available today for GERD and chronic reflux?
Surely, surely. So going down, first one would be weight loss, good sleep hygiene, picking smaller portions to eat, and making sure that the last meal is 3 hours before you lie down. Because once you lie down, gravity is no longer your friend. It is not going to keep the stomach empty. So that's step number one. Step number two is how often do you get reflux? If your reflux is occasional, that means you get it once or twice a week and it lasts less than 5 minutes or 10 minutes, then you can take occasional treatment. You can take over the counter Pepsid or Maalox or Mylanta, something that will work relatively quickly and will take care of your symptoms. If your symptoms only occur on beer or pizza night when you drink and eat big meals, then you could take an acid blocker before you go to your beer and pizza night. On the other hand, if you get reflux symptoms every day, they awaken you from sleep, then you need chronic therapy. That means you no longer have occasional reflux. Now you have GERD. So you have the pathological disease and you have to treat it like you treat any other disease, such as high blood pressure, diabetes. You have to take the right diet and the medication with it, which is generally acid blockers, commonly known as proton pump inhibitors or PPIs. There's 5 or 6 in the market. They are pretty much all comparable, and they are generally taken 1/2 hour before you start eating. And the biggest meal of the day for most of us is generally dinner. So a half hour before dinner, in case your nighttime reflux is bothering you, or a half hour before breakfast, in case your reflux is mostly in the daytime.
Okay. And so, aside from that, moving, past, well, I do have a question here that's asking how long is it safe for me to take my PPIs, my omeprazole or whatnot? How long is it safe for them to take it?
See, the answer to that question is that once you get reflux disease, your disease is lifelong. Therefore, your treatment will need to be lifelong.
Okay.
Now, are you comfortable taking something lifelong? That's up to you. That's a discussion between you and your physician to see what would be the best fit for you.
Right.
If you are in your 70s and 80s and you've got osteoporosis, then we still may recommend on-demand therapy because as we age, we tend to make less acid. But if you're young and you're of the athletic prowess and you do bodybuilding and you're active and this is significantly affecting your life, you may need to look at other options so that you can enjoy what you do without this being an impediment.
Right. Let's talk about the different options as far as, the traditional, obviously the TIF procedure, right? And then the traditional Nissen procedure. Can you talk about the different treatment options past the medical therapy?
See, if medical, before we go there,
Sure.
I would like to make a point that the people who do best with surgical treatment are the people who did best with medical treatment. So the
Okay.
people who responded to medical management will also respond the best to surgical management.
Fantastic.
And the TIF has revolutionized it because when we do the fundoplication from the inside, we do not damage the vagus nerve. The biggest problem with fundoplication in the traditional route, when you take a part of the stomach and wrap it around the stomach, was that the vagus nerve would get trapped. And so now these patients will get delay in emptying of your stomach. So the best analogy is think of the vagus nerve as a cable from a supercomputer, which is your brain, to your PC, which is your stomach. And you have gotten your cable now wrapped up. So now your PC is not working that good because the stimulus is not getting where it needs to get. So in
I,
order to keep your electrical cables going good, the less you tinker with that, the better off you are in the long run.
I
And
love that.
we are far away from those two areas where you can trap it. And that allows us to deliver a better product with less sequelae of delayed gastric emptying long term.
I
Because
love this. Yeah.
otherwise would replace one problem of reflux with a different problem of delayed gastric emptying. And the patient will come back and say, Doc, I am still regurgitating all the time. What's going
Right.
on? You told me your operation was a success, but that's not what I see. That's the issue.
I love that analogy. Wow, that's probably the easiest and best way to think about it. Let's talk a little bit more about the TIF procedure. Can you describe how that actually works? And then we've got quite a few questions that we'll get to, but I'll have you describe how the TIF procedure actually works.
Okay. So we decide on which approach we are going to take based on the endoscopy. If the endoscopy shows that the valve is not too loose and there is no big hiatal hernia, then the TIF can be offered as a standalone procedure in which we mount a special instrument over the endoscope and use it to grasp the inside lining of the stomach and make you a brand new valve, which allows you to eat and drink without getting reflux. If the hiatal hernia is very big, then what is done is we do a combined procedure in which the laparoscopic surgeon narrows down the opening of the hiatus through which the stomach has leaked up into the chest cavity, and then we do the TIF following that procedure. In essence, what we do is we grasp the inside lining of the stomach, pull it into the instrument, and put staples to make you a new 3 centimeter omega shaped valve, which replaces your own body's biological valve, which has become incompetent. So, utilizing the lining, a new valve is made to allow the body to function without need for long term medical management.
Thank you for that explanation. So We do have some questions that have come up. I hope you don't mind. We'll try to get through some of these questions. Let's see. We've got a question from Matthew. He's saying, can you differentiate between typical and atypical GERD? My spouse was diagnosed with atypical. Can you treat that with basically atypical symptoms with the TIF procedure?
See, it depends upon how much reflux they have. There is an entire subsegment of people who have acid reflux, but who also have symptoms of what we call esophageal hypersensitivity. They have a temperamental esophagus. That esophagus gets set off on a journey by acid reflux, but it's more than just acid reflux. Before TIF is offered to these patients, they need to have a Bravo study and motility. If the Bravo study shows that there is substantial reflux and the motility study is normal, then the answer is yes. If the Bravo study shows that the reflux is physiological or if there is a motility problem, then the answer is no. So
Fantastic.
it is playing a role, but we will tease out what role it is playing. If it is playing the dominant role, then absolutely.
Right.
But if it's not, then no.
And you'll determine which tests based on every patient, right? Which tests that would be appropriate for them to take, depending on their whatever symptoms they're having, correct?
See, if they are having symptoms which are very suggestive of reflux, and we endoscope them and we find terrible inflammation, which is called Los Angeles classification C or D esophagitis, that the entire esophagus is chewed up. For that particular person, very little additional testing is needed until unless you need it to satisfy insurance.
Okay.
But for other people who are reflux sufferers or the reflux is mild, or when you scope them, there is no damage to the esophagus, you need to figure out how much reflux is happening before you offer that.
Another question from Ray. They're asking, is coughing a symptom of GERD?
Coughing can be a symptom of GERD. It can also be a symptom of esophageal dysmotility. Some of the dysmotility disorders such as achalasia, diffuse esophageal spasm also present with cough. So what is done is, again in this instance, we do a manometric study to make sure there is no hypomotility or which is causing the reflux, and then do the Bravo testing. So yes and no.
Okay. Okay, thank you. Question, I had food poisoning after being on PPIs for about 6 weeks. It's the first time I've ever had it, and no one that had the same meal that I did experienced any issues. Could the PPIs have caused the food poisoning?
The answer is probably yes. What you're describing is called small intestinal bacterial overgrowth, or SIBO. The acid that we have in the stomach is not needed for digestion, but it functions as a barrier to stop the bacteria from the environment to get into the small intestine. So people who are on acid blockers are more prone for bacterial overgrowth and more prone for bacterial food poisoning. So yes.
Oh, okay. We've got Caroline. She's asking, I don't know if she's asking a question. Hold on. And it feels like my food goes into my stomach lining, and my stomach has developed a place where I go to the bathroom from the bottom of my stomach. I'm not sure what she's trying to say, but she's taking some basically a omeprazole version of it, and it feels like my food goes into my stomach lining, and my stomach has developed a place where I go to the bathroom from the bottom of my stomach.
See, all acid blockers cause some element of gastric emptying delay. And when you are eating your food, your stomach has to accommodate that food, so it descends down and presses on your colon. So it may contribute to some gastrointestinal hurry. But delayed gastric emptying is a known side effect of acid suppressive medication. So
Right.
that may be contributing, though it's hard to be certain.
Sure. Okay. And then we asked this question, Chad is asking, will this procedure allow someone to get off their medications?
That's the whole idea, that you can live your life without popping your pills. That's our hope. That's our hope. So far, the hope has been realized. There's a lot of data that backs it up. So yes, yes to chat. That's what we.
Fantastic. Let's actually talk about recovery time. That's a question we get a lot from patients. So what can patients expect kind of, day of the procedure and then recovery? What's the diet look like? What's their activity? How long are they able to work? When are they able to work again? Can you discuss that a little bit if you don't mind?
No, I'll be happy to. The day of the procedure, because the procedure is done under general anesthesia, you're going to be admitted post procedure and observed overnight. Next morning, we will give you a clear liquid diet, which generally continues for 3 to 5 days, and then we send you home with a dietary regimen. If it is done laparoscopically, there is a little bit of a surgical wound that will need cleaning and dressing. But short of that, there is no other problem with you going back to work later on in that week. The discomfort is very minimal with it. We just ask you to stick close to the diet. We divide it up over a 5 to 7 week period because we have made you a new valve. And so we want to be sure that we limit the amount of traffic that is going to go through till the staples have taken hold so that you will have a more robust effect in the long run. So we want you not to tempt your esophagus for the first few days with anything more than liquids. So clear liquids, then full liquids, then soft foods, but avoidance of foods that are very cold or very hot, because after having tinkered with the esophagus, it's a little sensitive. That's all. In
Perfect.
terms of activity, um, we generally tell them to avoid strenuous activity for a period of 4 weeks. So, their rumba and all of the other fun stuff comes with the 6 week mark.
Perfect. Yeah, we get questions all the time about heavy weightlifting. When can they get back to that? And especially, right, if they have a hiatal hernia repair,
Right.
probably have to stay away from that for a while.
Yeah, we want the packaging to fall into place in a good way. Don't want to tempt fate.
Right, right. We have a question from James. I know you kind of discussed this at the very beginning of the talk, but he's asking, does drinking less alcohol help GERD?
Very much so, because alcohol stops the gastric emptying in a big way.
Right,
That is why you retain far more of your food and you regurgitate far more than you would with other foods. So
right. Perfect. Thank you. Uh, Another question or comment from Andrew saying, my GI doc told me that a typical anti-reflux surgery will only create more problems. What are your thoughts? That's interesting.
I think you may want to rethink that, maybe get a second opinion from somebody who's not quite as pessimistic.
Right. Thank you. And then comment or question from Shane is asking, what should be the first steps if I think I have GERD?
So the first step is to see if you can control your reflux by limiting the amount of food you take in and then seeing how often you get symptoms. If your symptoms occur more than 3 times a week and last more than 10 minutes, then I think this would be a good conversation starter with your primary care physician to discuss how your reflux should be managed. If you are taking other medications, some medications can exacerbate reflux, and you want to maybe talk to them to see if they could change some of those.
So do you recommend that patients should talk to their PCP first, or can they come and talk to, let's say, like a GI like yourself?
Either works. Either
Okay.
works. This has been looked at, and it is felt that people who see more of me tend to be more compliant with medication.
Mm.
The people who see more of their primary care people tend to have a little less compliance because they feel that themselves that their problem is not severe enough. If you
Right.
feel that your problem is severe enough to see a specialist, then instinctively you do something about it.
Right.
Human nature is human.
That's a good point. That is a good point. So, you've been doing the TIF procedure now. I think you had mentioned about over 2 years. Do you have, or I should say more, how are your patients responding from the TIF procedure? Is there a difference of those patients that may have had the TIF versus previously had a Nissen procedure in the past?
Um, yes. See, in addition to doing people who have not had surgery, we have also done some people who had a failed Nielsen.
Mm,
So it goes both ways. And the people, because I was starting new, I picked and chose the candidates who would most likely succeed and who were the most symptomatic. So it's been most gratifying for me and for my patients both. We have both enjoyed this journey tremendously. They are off of the medication, and so far we have had good success and happy patient population. So uh, that is why it has bolstered me to offer it to even more patients with.
Fantastic. Thank you. One topic, we are in May now, but all of last month in April was esophageal cancer awareness month. So we ran some awareness campaigns in regards to that. But do you mind just briefly touching on, how GERD could potentially, evolve to something more serious like Barrett's and eventually, that as a precursor to esophageal cancer. Just kind of give the audience a little background on what the relationship is of GERD and esophageal cancer.
I'll be happy to. Long-standing reflux causes a change in the lining of the esophagus, and that change is called metaplasia, where one special type of cell replaces another type of cell. And once abnormal cells occur in the esophagus, that puts the person at risk for um, development of Barrett's esophagus. The reason for concern is that cardiac cancer or Barrett's esophageal cancer is the fastest rising cancer in the Western Hemisphere. And the at risk population, the people who are felt to be most at risk is overweight Caucasian males above 50 years of age. So for certain select populations, especially overweight individuals who are having reflux and regurgitation, the American College of Gastroenterology had a position paper which said that they should be offered once in a lifetime endoscopy because this is a biopsy diagnosis so that the esophagus can be biopsied and then they can be followed up. If they don't have Barrett's esophagus, then they never need to have another endoscopy. But that stratifies their risk. It stimulates people to control their reflux better and to lose weight. But yes, that's a significant concern in the Western because those numbers are rising.
Right. Perfect. Thank you. And then just the last topic that I wanted to touch on, and thank you for doing that, is, COVID. Is it safe to, everyone's getting vaccinated now. Is it safe to go back and have procedures such as the TIF procedure in this time? Maybe talk about a little bit about getting elective procedures in this COVID time, if you don't mind.
Yeah,
If you don't
yeah,
mind.
yeah. Thank you for that. We were not doing it when the at the height of the epidemic, but now living our lives again, within constraints. We still test people for COVID. We still advise people to be immunized, even those who have had COVID. After 30 days, we tell them to be immunized. Um, because once you have dealt with the epidemic, your rest of life's issues which have been pushed aside are now going to have to be dealt with one by one. So
Right.
we risk stratify. So we were talking to the cardiologist the other day. He says, look, people are still having heart attacks, people are still having reflux episodes, so life is still going on. And
Mm,
for that reason, once you have done the prevention that you need to do, immunization that you need to do, and all the behavior that you need to follow, all the other problems that have piled up, you need to address them. Reflux has been a significant issue because most people who have not been working or working from home have put on significant amounts of weight. Gyms have not been open, and so reflux has become a little more of a concern
Yeah,
for a
lots
lot.
more drinking too, right?
Yeah, probably so.
There is one question that has come up, and from Derek that I wanted to try and make sure we touch on. He's saying there's been lots of problems I've seen, or issues that have come up on the Facebook group about people getting back to their normal diet. Can you talk a little bit about that compliance and the post-op and making sure that you're following the diet, and he was just saying, do you have any thoughts on that?
See, what I tell my patients is that the guide that we give you is an approximation. Everybody is able to tolerate different amounts of food at different times. But because you have a new valve and it will take a little longer for solid foods to go down, in a sense, everybody is on their own timeline. These guides are an approximate, and your own body will tell you the signal when your body is ready to accommodate what you want it to accommodate. So,
Yeah.
be judicious. You will get your chance to eat whatever you want to eat. Don't try to force the issue. You
Right.
put in all this effort to get a new valve, treat it with respect, and you will enjoy life longer. That's all
Yeah.
I say.
Yeah, no, that's well said and very well put. It's almost like those bariatric patients that have to relearn how to eat and just eat
Absolutely.
differently. But so yeah, that's all the questions that we have today. One last thing I wanted to just give you the opportunity. If you had any advice that you would give patients, like the one main thing that they should do, what would your advice be to those patients?
See, for reflux sufferers, my best advice to them is that get good sleep hygiene and avoid trying to sleep on the right side. We know that you sleep on the right side, you get a lot more reflux and regurgitation at night. So, you know, try to get a good state of sleep, go into a state of zen, and so that your reflux will bother you less. And then if your boss hassles you, let them hassle you. Don't blame your esophagus for it.
I love that. Wow, that's great. Get good sleep. Get good sleep. Well, thank you so much, Dr. Bajaj, for being here with us this evening. I know it was very informative for me. I learned a lot of new things, especially your analogy of the vagus nerve. So I appreciate that. And I know everyone watching really appreciates it, and I appreciate you answering their questions. So last but not least, if you will, if you are in the Chicago area, you can find Dr. Bajaj. But if you're not, you can go to gerdhelp.com. We do have a physician finder on the website, and you can put in your zip code and or state, and you'll be able to find a physician near you. But again, I can't thank you all for joining us this evening, our TIF Talk Tuesdays, if you will. And Dr. Bajaj, thank you so much for joining us this evening. We really appreciate it.
Thank you.
So you're welcome. Thank you, and have a good night, and we'll catch you next Tuesday.